Welcome everyone to today's program. I'm Molly Gamble, Editor-in-Chief of Becker's Hospital Review. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Dr. James Porter joined Deaconist Hospital in 2000 as an adult and pediatric hospitalist and was appointed Vice President of Medical Affairs in 2002. He became Vice President of Quality and Innovation and CMO for Deaconist Health System in 2006 and Senior Executive Vice President of the Physician Enterprise in 2013. Dr. Porter serves on the boards of the Women's Hospital, the Heart Hospital, Health South Deaconist Rehabilitation Hospital, the Deaconist Clinic, and Farrell Hospital. Dr. Lisa Shaw is responsible for defining and implementing priority clinical interventions, IT workflows, physician leadership and alignment programs, and developing appropriate clinical solution recommendations for Evolent Health partners. Prior to joining Evolent, Lisa was the Medical Director of Population Health Management at Clinovation, where she led customers in leveraging technology and clinical workflow to create a comprehensive population health vision and strategy. Lisa also serves as an assistant professor in the Department of Medicine at Johns Hopkins University, where she participates in resident training and also serves as a practicing hospitalist. Mr. Steve Wigginton is responsible for leading the strategy, marketing, and health system partnership development for Evolent Health. Prior to joining Evolent, he served as the founding CEO of Medley Health, a venture-backed technology and services provider for physician practices, and was the president of Health Integrated, a leading provider of health management solutions that improves clinical outcomes and quality measures, resulting in lower healthcare costs. During his tenure at Health Integrated, the company launched award-winning care management programs targeting high-risk and chronically ill patients, driving revenue growth at a compound annual rate of 52%. It is now my pleasure to turn the floor over to Steve to begin today's presentation.
Thank you, Molly, and thanks for everyone joining us. Look forward to hearing from Dr. Shaw and Porter. I thought before we get started, we would set up a little bit of the framework for today's presentation by diving into a simple formula, but I think one that is helpful for understanding how winning the hearts and minds of physicians both is enabled by this movement towards value-based care and also, in fact, is quite dependent on it. I should say value-based care is quite dependent on success in winning the hearts and minds of physicians. And we'll talk about, through the course of our presentation here, some of the key drivers and successes. But to begin, I think all of us are well familiar with the general movement of accountability for quality and cost closer to the point of care. And there are many definitions in the market of value-based care and of population health, but at their essence, the idea that the accountability for quality and cost are closer to the point of care and therefore able to be impacted by physicians is a key part of the overall movement. The equation that you see on the screen here really reflects our belief at Evolent, and I think Dr. Porter and others in our partner health systems around the country, that first and foremost, there's a tremendous opportunity to create value by connecting and coordinating care, leveraging data and information, leveraging team-based care, proven programmatic approaches to treating particularly those that are multi-chronic or high risk, and that value creation is both good for patients and good for the bottom line. The challenge, of course, as you move across the equation is to make sure that those that are creating the value capture enough of it to sustain the effort. So physicians who are doing more work, hospital systems that are investing in programs, need to make sure that the reimbursement structures under these value-based deals are adequate, both in terms of deal terms, but also arguably more importantly, in terms of the data and operational requirements that sit inside of those arrangements, and also the quality measures and other metrics that drive the reimbursement structures. As we'll learn today, physicians have a real opportunity to both impact the value creation, but also impact the ways in which this value is captured over time. And as you move across the page here, one thing that's clear is that if you get both of those things right and can drive the right number of lives with the right pacing, the provider systems can achieve success, which is represented on the far right-hand side. Regardless of how you drive to success in value-based care, there are a number of things that had traditionally been on the payer side that are now being delegated or migrated into the provider setting, while at the same time you've got investments and efforts on the clinical decision-making side. So you're really seeing, as we show here on this graph, care management, utilization management, risk adjustment or RAF, quality metrics, things that payers have traditionally been very focused on and have done a reach around, if you will, the providers in order to try to impact those things that both impact quality and cost. On the lower side of the graph here, the efforts that are embedded in the physician practices around clinical effectiveness, decision support, performance management, productivity, efficiency, all of those things that are happening within the workflow of the provider system actually have much more sustainable long-term value. And both of them, we would argue, are required over time in order to migrate from a predominantly fee-for-service environment to a value-based reimbursement environment. I think if we think about winning the hearts and minds of physicians, we have to first acknowledge that it is a difficult task. The declining fee-for-service rates have had a tremendous impact on providers, tremendous in a negative way. Reduction in Medicare payments, savings from cuts to critical access hospitals, CMS payment reductions on a fee-for-service basis. So all of this pressure, generally speaking, has translated into more difficult work environments, more pressure on the physicians in their practices, more consolidation, more employment, more change. And change, while generally, usually good over time, is most often not great in its initial experience. So these pressures in many ways have driven a lot of improvements in the practice setting, but they've been primarily volume-oriented and scale-oriented. One of the things that's attractive, if you will, about the migration to value-based care is that it creates an opportunity to have a different discussion within the physician enterprise and within the physician practices, and hope that the focus on quality and the focus on a different care delivery model with a reimbursement structure that rewards excellence actually can provide some relief to what has been and what is forecast to be a pretty daunting financial and reimbursement picture on the fee-for-service front. I'm sure everyone on this webinar is well familiar with the facts around physician burnout and the challenges of less time, more volume, more documentation, more EMR implementations, more patient dissatisfaction, which is probably the most challenging, particularly for a cadre of professionals who have dedicated their lives to caring for patients. To be in a system that dissatisfies those patients and puts them in a less than optimal care delivery model is really challenging. And what we've seen certainly at Evolent, and I think in our prior experiences here as panelists before we came to Evolent, is this makes for a very skeptical, very challenging audience. When you talk about winning the hearts and minds of a group that has a group of physicians that have experienced environmentally challenging last X years, 10 years. The construct around value-based care as a lever or a means to impact the physician enterprises in a positive way is outlined on the slide here in front of you. First, we see a health system environment or an IPA environment or a community environment where there are initiatives and investments in population health. And so PHSO from a little acronym alert here, Population Health Services Organization. A physician enterprise, and Dr. Porter will talk about what they're doing at Deaconist. They're committed to providing an infrastructure that adds capability, capacity, team-based care, programs, analytics, and information to support the physicians, as opposed to the traditional payer model, which again was more of a reach around, try to get to the patient, try to move things around. That resource investment represents a tremendous opportunity to engage physicians in a different dialogue than has previously been possible. There are always early adopters amongst the practice settings, but there are also those that struggle to catch up. And so the conversation today that Dr. Shaw and Dr. Porter will lead really focuses on how to avoid, how to take advantage of early adopters, how to set up a governance structure that makes these conversations possible, how to address those practices and those physicians that aren't able to move as quickly, and then how to think about the incentive alignment so that it paces with the value creation. So much as on the prior slide we talked about creating value and then capturing value as a sort of global provider challenge as you move from fee-for-service to value-based reimbursement, you can really take that down into the practice level. And to what degree are the improvements and changes and leveraging of team-based care and other things manifesting themselves in terms of improved opportunity? And as you see on the slide here, the numbers are quite substantial. So for an average 5-physician practice, there's more than $200,000 of annual profit that could be generated from process improvement and standardization of care opportunities, as well as increased access opportunities. But those are dependent on a connectivity to a broader ecosystem, which is what we're trying to represent here. So key points as we transition to Dr. Shaw and Dr. Porter would be, value really does represent an interesting opportunity to have a different conversation, moving the interaction with patients, the accountability for quality and cost closer to the point of care. It needs to be executed in a way where it respects the skepticism and the burnout that exists currently, but with the right kind of infrastructure investments can be a way to really unlock value in the future. And that's really the gist of how we think about value-based care and its relation to winning the hearts and minds of physicians. Dr. Shaw?
Great. Thank you, Steve. Good afternoon, everyone. I'm excited for the opportunity to share with you the key principles for success on this important topic, winning the hearts and minds of physicians. Before I expand on our 3 key pillars and principles, I want to begin with talking about our foundational first step on the next slide. For engagement strategies to be successful, systems must first establish a strong governance structure. And this governance structure really does need to manage strategic and business priorities, as well as population health initiatives for the system, giving physicians a distinct voice and a seat at the table. We've seen at Evolent great success in creating these physician advisory councils or committees, or what we term PAC, across several of our partners. The PAC, as you can see here, is a governance structure at the system level, and we generally recommend it be composed entirely of practicing physicians that represent a diversity of primary care, specialty care, employed and affiliated providers. And these PACs can be established both at the system level with local area PACs across regions or pockets in your network. Most importantly, and something I really want to highlight based on what Steve just said, the lack of this type of action-oriented and empowered governance structure can result in an amplification of some of the challenges and issues Steve described a few minutes ago. Later in this webinar, Dr. Porter is going to be able to share some stories on the success of the PAC at his health system and its impact. But at this point, I think it's important to emphasize how essential this foundational infrastructure is as a first critical step. So moving to slide 10, once you've built this foundation, there are 3 key principles that will set the health system and your providers up for greater success. And you'll see how this foundational governance structure that I just described will play an essential role across all 3 of these pillars. So the first pillar, quickly, we begin with is increasing efficiency. And while this might seem simple, it's actually very important for a system in the PAC to focus on efficiency in practice workflow, as well as efficiency over prioritization of interventions and patient care, which is driven mostly through the availability of good data. If efficiency is your first pillar, the second pillar is the ultimate goal, which is to elevate and enhance patient care. Through access to evidence-based protocols and tools and technology, a patient-centered care team, practices can be empowered to deliver the highest quality of care. When we get to this section, we will walk through an example of care gap closure at the point of care. Lastly, the third pillar, if you are really going to win the hearts and minds of physicians, is rewarding top performance. This includes not only incentive redesign, but also negotiating value-based contracts, leveraging the physician perspective. I'm going to dive deeply into each of these three pillars at this point. So on slide 11, we can begin with principle 1. This is increasing physician efficiency, a critical aspect of the engagement process. On slide 12, I presume many of you are very familiar with this picture of a practice. Many practices struggle with inefficiency. And as you can see here, we've got a photo of a practice that we've been working with at Evolent, where you'll see paper everywhere. There are many sources of inefficiency, high levels of paperwork, and all of this is happening across multiple initiatives from multiple different payers. In this slide, we're looking specifically at an example of a payer initiative that these practices were working around called risk adjustment. I thought I would first start by defining risk adjustment. Risk adjustment is the analytical process that's used by CMS, state agencies, and commercial entities to account for the risk of a patient in a specific insurance product. The risk score is a numerical figure that's assigned to a patient and reflects their complexity or their level of risk. And the score itself is heavily dependent on accurate documentation by physicians or providers in the care setting. And the level of that score is used to compensate providers for their complexity of their patients. Often, as this picture depicts, physicians are juggling initiatives across many payers. And in this example, you can see a process that's not really well integrated into practice workflow and efficiency. This results in physician and care team frustration across the board and often a suboptimal patient experience. Ensuring integration of all initiatives into the practice processes and maintaining the most efficient practice workflows can make all the difference for physicians. In this example, by integrating RAF worksheets directly into the electronic medical record, not only were we able to reduce manual administrative time, but we are also driving enhanced patient care by allowing physicians to address the complexity of patient conditions in the exam room at the point of care. This can lead to an increased satisfaction across the entire encounter, both for the provider and the patient. On the next slide, 13, we note that if addressing workflow is one area of opportunity in most practices, what really matters is getting to better care and better value. So the efficiency of giving actionable data at the point of care to physicians and being transparent with them is really important. Using physician reporting in a way that can maximize performance and maximize patient care can be quite challenging, and I'm sure many of you have struggled with this in your own practice experiences. But with successful, timely, physician-centered reporting, providers can prioritize opportunities and have a continuous improvement for their practice. Using actionable quarterly, monthly, and semi-annual reports, care coordination, team-based care, patient satisfaction, all of this can be enhanced while simultaneously allowing providers insight into their individual or practice-based opportunities for financial and quality improvement. Moving on to slide 14, I've talked so far about a governance foundation, and now we focused on actionable data and workflow. But I'd like to move on to the most challenging, however, the most rewarding pillar, which is really elevating patient care to a new standard. None of anything we've spoken about so far really matters to physicians if the quality of the care they're delivering isn't the best. So on slide 15, I'm going to start by outlining the three fundamental aspects of what it takes to improve patient care to this new standard. And it's three things: right tools, the right people, and the right technology. When we talk about tools, what we mean are rules and workflows that can drive standardized, best-in-class care protocols, delivering the best patient care. It's very important to tie this back to the governance structure and note that these workflows and tools have now been created by your own PAC or your similar physician structure that's been in place. Physicians are much more likely to embrace these workflows when they've built them themselves. When we talk about the specialized care team, we're talking about a team that's dedicated to supporting the physician and the patient and ensuring that the best, highest quality care is being delivered both inside and outside the four walls of the practice. Care coordination across the continuum is not a new concept. I know we're all very familiar with it, but it is elevated to a higher level when your care team, just like your providers, require actionable data and transparency into their own performance. And the performance of your care team is now measurable. Finally, technology is the third element, and it's last but not least. A platform that connects the practice EMR and the technology outside of the physician's office is needed to ensure data sharing, continuous monitoring, and care coordination across the continuum. So let's move to slide 16, where I'll take an example of how the tools, the technology, and the people can all come together. Today, I'm sure many of you can relate to the challenges we're depicting on this slide on the left-hand side, describing the care gap closure process. Something so simple but can prove quite challenging. Often there is a manual process delivering multiple point-of-care checklists, and half of the time these point-of-care checklists are different across different payers. Documentation can be challenging, either within your own EMR or on a paper checklist. And ultimately, most providers have very little insight into which care gaps are open and which ones are closed. Today, many EMRs and workflows are not configured to support effective care gap closure, especially across different payers. Now, to the right of the screen, we outline solutions. If you can envision a world where care gap closure is automated and makes the workflow for the physician and care team simple, the impact on the practice and the patient is immeasurable. So what is this impact? Not only ensuring that resources are used effectively and the care team is actually operating at their highest licensure with streamlined and efficient workflows, but you also are elevating patient care. You're addressing missed care gap opportunities at the point of care and having a better experience for both the provider and the patient. Once again, this entire redefined care gap closure process delivered at the point of care has been created, approved, and communicated by the physician leadership of the PAC. The final principle, moving to slide 17, is around rewarding top performance. And we're going to hear from Dr. Porter in a few minutes about how creating an impactful incentive model is basic to winning the hearts and minds of physicians. But I'm going to highlight two specific elements of this principle. Moving on to slide 18, I'd like to take a second to talk about incentives. Incentives to improve performance and enhance quality of care are table stakes when we speak about winning the hearts and minds of physicians. A discussion on moving and shifting to value cannot be had without an initial discussion around incentives. This incentive discussion should ideally begin with the PAC and engage providers across the organization to create an incentive plan that supports the desired behavior change. And as you can see with this curve here, we'll talk a little bit about the length of time it takes to create this type of incentive model. But just to recap, if you've built the foundational governance structure, you've armed practices with efficiency in their day-to-day workflow and data transparency, and now they have tools, technology, and a care team to deliver the highest quality of care, physicians can now be ready to be held accountable and can be provided with new incentive plans that can support the continued move to value. Initially, in the early years, when they're learning the behavior and beginning to transition, activity incentives are helpful. It can really support the change in behaviors that are needed to shift to true outcomes-based care. This process can take up to 3 to 4 years, but at that point, systems are able to achieve an incentive model where there is a profit and loss sharing option and providers are ready to take downside risk. And we're starting to see this with many of the partners we're working with. A few key final points around incentives and incentive design. One is that it's essential in the early years to make your incentives simple, measurable, and defensible. In order to achieve this, actionable data, physician reports, and transparency for providers must be in place, as well as that foundational governance structure that's building the incentive model to begin with. Finally, I'm going to move to slide 19 and end with one of the most unique aspects of winning the hearts and minds of physicians in today's healthcare landscape from my perspective. And this is really around changing the basic premise of how deal negotiations are occurring with payers today. In order to create measurable and defensible metrics for performance incentives and to shift behaviors towards accountable care, deal terms with payers and metric selection for performance need to be looked at from the provider lens or point of view. Ultimately, when health systems are leading the negotiations without the physicians, there is less impact and value for the providers. But when physicians from your PAC or a similar governance structure are leveraged, mutually beneficial and financially sustainable deals are more probable. So in summary, the key points of this section are that a foundation through a physician-led governance structure with key roles and responsibilities across driving the transition to value is required. Then the governance structure should focus on the three key pillars or principles, including efficiency through workflow and transparency of data, elevation of patient care through team-based care tools and technology, and finally, rewarding top performance through incentive redesign and engagement of physicians in deal terms. I now would like to turn it over to Dr. James Porter, Chief Medical Officer at Deaconist Health, who will talk about putting these principles into practice and the direct impact it has had on the physician enterprise at Deaconist Health System.
Thanks, Lisa, and just like to echo how happy I am to be on the call today and able to share a little about Deaconist Health System and our journey on this population health initiative. So I'll start with slide 21 and just briefly tell you a little about Deaconist Health System. We're at the third largest city in Indiana and situated in the center of a pretty rural population in 3 states. We're a 5-hospital system. We have a multi-specialty group of employed providers and still a fair number of independent providers who provide critical resources in our system. We were an early participant in the Medicare Shared Savings Program, and today have an extended network of participating providers, both our employed providers and affiliates, in what we call the One Care Network, and that's based on an infrastructure that financially is centered around partnerships with existing commercial payers. While we're large enough to engage in population health management and be able to partner with a company like Evolent, we aren't quite big enough to stand up our own health plan and therefore had to look for alternative ways to be able to establish a financial model that was sustainable for us. On slide 22, I just wanted to talk a little about specifically the concept of winning the hearts and minds of physicians. Obviously, there are lots of different moving parts that Steve and Lisa have already touched on with regard to population health management and creating a value proposition. Winning the hearts and minds of physicians is obviously a critical piece of it. I like to talk with people about the work that we're doing through the One Care Network as a 3-legged stool. Above that 3-legged stool, though, is a covering, and that's physician engagement. If you don't have physician engagement and participation in decision-making as an overarching theme of the initiative, it's really difficult to make progress. So when we go out and talk with physicians about their role in the One Care Network or about participating in the One Care Network, there are a couple of principles that we try to keep in mind. The first is that while they may not love the way that they are reimbursed today, most physicians have grown to a degree of comfort with either the RVU model or a net receipts model, whatever underpinning there is for how they get paid. They've grown kind of comfortable and they know how that works, and they know how their work translates into their income. The other thing we try to keep in mind is that there aren't a lot of providers out there whose perception of their own work is of poor quality. And we certainly don't want to go out implying that we believe they provide poor quality. And it's easy when you're talking about the things that you would like to do to help a practice to put things in terms that to a physician in their current paradigm sound a lot like you want me to do more for less money, and you're saying you want to do that because my quality is poor, and nothing could be further from the truth. So we try to center the conversation, first of all, around the triple aim. It's something that we all can understand, everyone can engage around, has become pretty prolific as a fact that we all embrace. And as you know, that's better care, better experience, and lower cost. And we feel like as long as we remain grounded in a conversation around the triple aim, we can't get too far from our guiding principles, and that will help us avoid mistakes. So when we sit down and talk with physicians about their role in the OneCare network, we like to talk about what we think it will do for them. And the first point we make is we'd like to help our physicians systematically identify the most complex patients who are attributed to their practice. That's a big undertaking in and of itself, and something that we had stumbled with in the past and had caused frustration for our providers. So being confident in our ability to appropriately risk stratify the population and then attribute the right patients back to the right practice is really a key commitment to be able to make. Secondly, we say we'd like to provide you with more resources to take care of those most complex patients in your practice. And notice that it's not us saying we want to help you provide better care for your patients. We want to give you more resources to help you provide the kind of care that we know you would like to provide to your patients. As Lisa pointed out earlier, and Steve as well, many physicians feel like they're on, I've heard it referred to as the hamster wheel. They're going door to door seeing patients and knowing often that they leave a room with an encounter that wasn't entirely satisfying for them nor for their patient. And that's one of the drivers of physician frustration and burnout that we believe our model of population health management can help alleviate. We use people and technology to help bridge those gaps, and those are some of the resources that we commit to physicians who participate that we will provide, and that we make that investment, and it's really given to them as a tool. Additionally, we make it clear that we want to reward physicians for the role that they play in helping us achieve the goals of the network. That gets back to alignment of incentives. As Lisa said, if we don't have incentive alignment structured properly, it's very difficult for physicians to see out of the paradigm that they live in, day out. And as I said, while they may not love their reimbursement model, they know it and it works for them on some level. So being able to bridge that gap, another critical factor. We also make it clear that we'd like to include physicians as we set the vision and goals of the network and set priorities for what we should tackle first. There are lots of opportunities, and deciding what's the most pressing priority that we should take on first really is best, those decisions are best made in the hands of the practicing providers within the network. It allows them to see that the pain points for them, and as advocates for their patients, the pain points and breakdowns that they see for their patients really are where we want to start, not what we would as an administrative team necessarily prescribe to them, or I should say prescribe to them. We also want to include physicians in that decision making around incentives. They are really best equipped to tell us what they want to do and really don't require anything for it, and what really is representing something that they see as a change in workflow or additional effort that may in fact take away from their ability to generate their income if we don't have some gap replacement in place to help overcome that. We also want representation in governance for physicians, and so for both our Medicare and commercial ACO, the majority of our board is made up of practicing physicians. Our PAC, as Lisa pointed out earlier, is made up entirely of practicing physicians, and many of the board's responsibilities are delegated in large part to the PAC around priority and goal setting and incentive alignment. Finally, we commit to providers that we will make every effort to be good communicators, and that we're committed to transparency throughout the organization. So as we have data and information, we do our best to put that in a format that's easily digestible and understandable, and to share that in a timely manner and with a regularity that providers can come to expect. Moving on to slide 23, I thought it would be helpful to highlight a couple of new approaches that have really been born out of the work of our PAC. As we engage members of the PAC, and they in turn engage members of the pods that they participate in, which helps us drive information and receive information down to the grassroots of the provider network, they're able to come forward and tell us places that they see us having opportunities to do better. One that was identified early was within our integrated electronic medical record, it was almost impossible for providers to see whether a patient that they were seeing at that moment was someone attributed to the value network or not. And clearly that caused difficulty with communication and being able to integrate care across different settings. So one of the first technological innovations that we set about trying to develop was a banner within our electronic medical record, and we've been able to do that. So we're able to take all the lives that are attributed through various payer relationships that we have and identify them, and then put a banner on the opening screen of their chart within the EMR that says this patient is attributed to the OneCare Collaborative. Additionally, if that patient has a care advisor who's been assigned to them, it tells who that care advisor is and gives the care advisor's phone number so that they can serve as a conduit of communication across various care settings. It also, interestingly, identifies patients who haven't been engaged in a way that would allow them to link up with a care advisor, and helps us see that as a gap and make efforts to close it at every encounter that we have with that patient across the system. Another development that we have had is we started with primary care doctors on the PAC because initially really this was much more of a primary care initiative. But it wasn't too long until our primary care doctors started identifying places where specialists really could be impactful to the priorities that they had helped us establish. And that led us to wanting to organize our specialists in a way that they could start to engage with us around what our priorities were and what role they, and especially people in their like specialty, might play in helping us be successful. We were a little concerned at first that the specialists might just see this as a way to reduce their workload. It's been really refreshing to see that just like our primary care doctors who got into healthcare in the first place, almost to a person, because they wanted to help people, because they wanted to make a difference in their patients' lives. Specialists are very much the same people, and they're easy to engage, much easier than one might think, around things that we can do to make care better for our patients. And again, if we stay centered on that triple aim, it's something that we can all embrace and work around. Communication is key. We've come up with a number of different newsletters and email systems that we use to try and push information out on a regular basis to our providers. What we don't want to have happen is go out, talk with them about their role in OneCare, start them down the road of being fully participatory in our network, and then have gaps where they feel like they've lost touch or that we've forgotten about them. And so we try to have frequent touch points with them with valuable information and communication. On slide 24, we address some of the outcomes that we feel like we've been able to achieve through the work with our PAC and our governance model. I'd like to highlight one particular initiative that we undertook as a way that I think covers a number of the different bullets on this slide. As Lisa pointed out, a really important competence to have as a value network is success in RAF scoring. For providers, RAF scoring is burdensome in a manual setting. Even if you have someone out there who's filling out part of the form for them, it's just an additional step that in a provider's mind really doesn't clearly equate to them providing care for their patient. So in order to drive success in RAF scoring, the very first thing we had to do was educate providers within our network about why it was important. not only for us as a value network participating together, but also for them individually within their practice and ultimately for their patients. And so we use the LEAP training format to be able to get our providers together and give them essential information about why they should care about RAF score. And our PAC were really the first ones provided that education, and we knew early on that it resonated with them and that it wasn't going to be a difficult message for us to deliver. We just had to have the right structure and format to get it out there. In addition to educating providers about the importance of RAF scoring, we knew that we had to have the right incentive in place because it was going to take them more time, and for providers on a net receipts or RVU basis, that means fewer encounters, which ultimately can mean less compensation. So we needed to have an incentive in place that would help bridge that gap. And as Lisa's continuum slide pointed out, early on in the process, really some very process-oriented incentives that says, if you do this, then you will receive that, is a great way to start connecting the dots for providers about how the efforts that they put forward not only benefits the network and their patients, but also helps keep them whole and is beneficial to them financially as an individual. So we educated our doctors about RAF, and we put an incentive in place, and we were seeing that they were doing much better at being successful in identifying the HCC codes and completing the RAF scores, but it still was more work for them. And ultimately, one of the things that we would like for our population health efforts to drive is that doctors actually see taking care of their most complex and most difficult patients as an easier task with the network in place than it was before the network. And so another opportunity for us to innovate was by looking for a way to use our electronic medical record to automate some of the processes around RAF scoring. Working with Evolent, we were able to do that, and now have been able to, again, satisfy our providers in a way that says the people who are making decisions and setting priorities within these efforts really do hear us when we say there are things that are difficult for us or things that are pain point for us, and they're making real efforts to put solutions in place to help us. And you can see on the bottom of this slide some quotes that we're taking, I'm proud to say, from physicians who participate in our OneCare network. And we get the same kind of feedback not only from providers but also from patients. Patients who had experienced a significant amount of frustration, often people with not just medical issues, but social and other complex confounding factors, who were pretty frustrated with the health care they were receiving, frankly, from our health system before we started this journey, who now tell us that they feel more attended to and that their needs are being better addressed than ever before. And that's rewarding for the providers, it's rewarding for us as the health system administrators, and obviously rewarding for the patients. So that's the end of my piece, and I think that takes us to question and answer.
Fantastic. Thanks, Dr. Porter. So I actually, while we're pulling together some questions from the audience, I'm going to ask you, Dr. Porter, if that's okay, a quick question. We talked a lot about the foundational governance structure throughout this, and you touched on it as well. When you think about standing up the PAC, could you describe a little bit how Deaconist approached it in your network, where you have both employed as well as independent providers, and what that looked like and felt like in terms of both composition of the PAC as well as any other of the key layers that had to be a part of how you thought of that governance structure and how it made its way to the physicians at the ground level?
Sure. Well, the PAC plays a really important role throughout the entire health manager, but especially early on. They really are your voice in a very credible way. And so it's important to get the right people on there. And it's important for there to be diversity of representation, because it does matter to non-employed providers, for example, that someone who they see in a similar situation as themselves has a voice in leadership and governance of the network. Additionally, it's important to pick people who are thought leaders and who are seen by their peers as someone that makes good decisions and someone who they might want to pay attention to what they're up to. So getting people who are engaged, people who want to commit the time, because there certainly is a commitment associated with really fully engaging in reviewing all the materials and coming prepared to meetings for a robust dialogue. And then just diversity of representation, I think, is the other really important factor. I think that we've gotten more traction out of being able to honestly tell people that every voting member of the PAC is a practicing physician within the network, and then being able to further tell them that the PAC really is the decision-making body about how we establish the physician quality incentives and how we align our priorities around implementation of changes to the care model and other things like the EMR. That really resonates with providers.
Great, thanks. Thank you, James. Molly, can I pass over to you to take some questions from the audience?
Absolutely. So yeah, we will now begin the Q&A portion. We've had a lot of questions roll in. Let's see here. As a reminder, if you're still listening, we can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. The presenters will attempt to answer as many questions as we have time for, and they'll be following up on questions they don't have the opportunity to address. So a couple that came in here. Dr. Porter, this one is for you. You spoke about functions like and case management. Why are those functions important? What functions should you take on within your physician enterprise to get greater control of total cost and quality?
Great question. I think it's something that we have often overlooked as providers. The insurance companies really have, by and large, owned those functions previously. And as we engage with payers around the parts of what used to be their work that we would like to take, often it's challenging for them to see their way clear to cede control of that. But we're pretty adamant that as you go down the path of value-based reimbursement and risk-taking, it really is incumbent upon the network to have the ability to take those responsibilities on behalf of their providers. So, for example, we don't want the insurance companies being the ultimate decision makers around what is appropriate utilization and not appropriate utilization when we're taking risk on the medical cost of care for those patients. And and yet that's something that you do need to have a process in place to be able to manage. You can't just say, well, it's a free-for-all now and anyone can do anything that they want at any time, but at the same time you do want to have control of that. So having the right people in place to provide utilization management, and then of course case management for us really is very akin to care management, and that is making sure that we're closing gaps between different care settings, that we're anticipating patient needs, that we're setting physicians up for success in individual encounters, knowing what kinds of issues are driving problems with compliance or success with different treatment regimens for their patients. Those are the kinds of things that really make a physician's practice easier. For us, I think we would have struggled for a while to establish the right infrastructure to be able to do that, were it not for our partnership with Evolent and really the already well thought out base model that they have in place for how you should staff that and who should play what role.
Okay, thank you. Dr. Shah, this question is for you. How important is reporting and analytics to obtain buy-in? How do you get the physicians to believe the data so they can change their behavior?
Great question. Thank you, Molly. It's incredibly important. So we talked a lot about the importance of transparency of opportunities for improvement for providers, especially when both patient care outcomes and financial outcomes are tied to these data elements. I'd say there's three pieces to the data that are critical. One is that it's accurate. The second, that it's easy to understand. And the third is that it's actionable. So real quickly, accuracy of data. Physicians are not going to believe the data easily if it's not accurate. And you have one chance. That's it. just one chance of putting the data in front of physicians. And if it's not correct or it doesn't actually reflect the care they've delivered, they will not trust that data again. This is important clinical information. So it's important to know that you're getting accurate data from the get-go and that data is also aligning with what they're seeing within their own medical record. If you are unsure of that, there are areas of improvement that can be done to make sure that the medical record is appropriately capturing. And sometimes that's a critical part of this, is any data that's being pulled out of the EMR is appropriate and is documented the most effective way. The second thing I'd say is that the data needs to be easy to understand. So how you present the data to the physicians is important. We talked about defensible, simple, measurable metrics. Well, same thing with the data. It needs to be straightforward. Tell me my denominator, tell me my numerator, let me know what I need to do and where I'm performing in a very simple manner, because I don't have 100 hours in a day extra to be trying to understand this complex report. The third thing I'll say is it's actionable. Tell me what to do with it. So it's fantastic that I have this knowledge, but now how do I fix it? How do I move the needle on performance and continue to deliver the highest level of care? And I think if all three of those things are kept as key principles for data management, you can get physicians to believe in the data and you can get their buy-in, and they will actually find that data to be valuable and use it in their day-to-day practice.
Okay, great, thank you. So we had quite a few questions come in about the PAC. So this one, I believe Dr. Shaw, Dr. Porter, eager to hear your thoughts on this. I think it especially connects to the point you raised earlier about burnout. This attendee asked, how do you get physicians to volunteer and participate in the PAC? Many physicians fail to get involved because they don't have time, and historically they've never seen results from these types of committees.
James, do you want to take that?
Sure, yeah, I can tackle that one. I shared that same concern and sentiment as we started this journey. We don't pay our providers for participating on the PAC. They haven't asked for any compensation, and they come faithfully and willingly to the meetings. We do try to schedule the times such that they have a minimal impact to their day of providing patient care. I think as doctors hear what we're trying to accomplish, it resonates with them. It's how they've wanted to do their work all along, and really have, the historical mechanism of how they get compensated has been an obstacle to that. And so I think being offered an opportunity to start to see that historical paradigm that's been very frustrating for them change is engagement enough to get doctors to coming to the meetings and participating very robustly in the dialogue.
Okay, and then this question is also about PACs, but what level of autonomy or decision-making do you give the PAC? More of a true voting board, or is it more of an advisory board? Dr. Shaw, maybe you can take that one.
Sure, happy to. So, I'm sure James could add to this as well. We want this to not be a committee of advisory. We know physicians have been doing that for years, and it's not going to move the needle if it's just another Me Too group. And so we typically try to make these voting or board influenced roles. So potentially your PAC chairs are sitting on your board of your population health entity and driving decisions up, or they are making recommendations that are quick and very tactical. And often, if they're highly clinical, those recommendations are taken as the word. And so we generally try to change the meaning of this committee, how this committee functions, and how decisions coming out of this committee or council really are taken by the health system and the board. So I'd say it's a variety of ways across systems we work with, but generally speaking, this does have a voting right, especially around decisions that are clinical and physician related in nature. James, anything to add to that, or would you agree?
Yeah, I agree, and I would add that we definitely do see ours as a decision-making body and not just an advisory body. However, those decisions are made within a certain framework and context. So I'll give you an example. When we started this work, we knew that we couldn't just go to physicians and say, hey, folks, if we save some money in the future, that will create a pool of funds that we'll then use as a way to deliver incentives back to you to help with alignment. We knew that it had to be more tangible than that. And so we've actually prospectively funded on an annual basis how much our budget says we should be able to put into physician incentives. And we've actually funded that in the early years beyond what we were being able to bring in revenue off our contracts. And so we go to the PAC and we say, hey guys, here's how much money we have to spend on physician incentives next year. Help us figure out how to spend it. So they don't have a blank checkbook, but they do have the ability to make the decisions within those parameters.
Okay, thanks, Dr. Porter. So we have time for one more question here. Dr. Porter, I believe this one is directed at you. Can you talk more about the communication done with patients and how it benefited your physician?
Yeah, that's a great question. We haven't gotten really that much into the actual clinical model of care today, which is a critical piece of success in this. And the clinical model of care really is built around patient engagement. So our care advisors, as we go into a practice and we do risk stratification and we create a roster of patients and then use the physician as sort of the final decision maker on who should and shouldn't be on that roster for their practice, the care advisor that works directly with that practice starts actively working that roster and identify the technology that helps us with the risk stratification and getting claims data and clinical data into the same location actually will help a care advisor know how to prioritize that work both from patient to patient and then for any one patient how to prioritize sort of step 1, step 2, step 3. So as we're bringing patients in for something called a super visit where the physician would be completing a care plan or following up on an established care plan, those care advisors are proactively reaching out to the patient well in advance of the visit, finding out what's going well for them, what isn't going well for them, what their compliance is like with their medications or any testing or procedures that may have been ordered for them. And by the time they get in to be with the provider in the exam room, a lot of information has been gathered, and often the care advisor will actually be in the room for all or part of that encounter to help bridge the communication. And what that does is it allows the provider to be able to accomplish a lot more in a lot less time. And then after that encounter, the care advisor again does follow up with the patient, reconciles their medication, talks with them about how they're going to get new prescriptions filled, follows up with them about subsequent testing or other information that they need. And really that kind of gap closure is what makes the experience better for both the physician and the patient.
Okay, thank you, Dr. Porter. So that concludes the Q&A portion of the program. I want to again thank our presenters for an excellent presentation today and for all of you who posed questions and participated with us. We look forward to having you join us for future webinars. This concludes today's program. We hope you have a wonderful afternoon. Thank you.